topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Inarticulate speech, inarticulate speech of the heart. Inarticulate speech, inarticulate speech of the heart. Inarticulate speech, inarticulate speech of the heart.
Hello and welcome to It's Your Voice, the show that hosts enriching conversations in diversity. My name is Bahia Yackzan. I'm a core alignment coach, an emotional wisdom training specialist, and a diversity educator. Tonight we have a really special guest talking about a very powerful topic. We're going to talk about cancer and get an overview of cancer treatments, detection, and inequities. But before I introduce my guest, who is very dear to me, Dr. Susan Yackzan, and before I share with you her many credentials, I wanted to just remind everybody to go back and download some podcasts of our previous shows. It's, wow, almost New Year's. Happy New Year's, everyone. And just thinking of the year in review, just want to highlight, I've learned from every single conversation. The guests are amazing, very educated from all sources of education. And some of them are like the very first one I did was on climate resilience with Kwabena Asante, Dr. Kwabena Asante, which was very enlightening. There was one by the portrait artist and activist Robert Shetterly on Americans Who Tell the Truth. We've had several different First Nation people from different communities talking about cultural fire burning, cultural activities for health. We've had Kamika Edwards, a counselor, talking about Black student unions, Black staff unions, and the differences they're making for students at schools. And Reggie Harris was recently on, a musician who creates these brilliant lyrics out of history, lessons from history, and just totally rocks the music, and just brilliant perspectives. And that is honestly just a handful. I'll just mention one more, one with Erin Santos, who identifies as a transgender woman, talking about biological sex and gender. And we're just really in tonight, it's just going to be also very incredible information to share with anyone. I think this is going to be a really valuable show, and thank you for tuning in. And I will just remind you, all of our podcasts are available on the major platforms like iHeartRadio, Pandora, Spotify, Amazon Music, Audible, Google Play, and several other outlets. And of course, W4CY Radio. You can hear it live or view it live, or Talk4TV, YouTube, Facebook. So enjoy the shows in 2022 that we did in 2021, and keep listening on Wednesdays. So Dr. Susan Yackzan, yes, my sister-in-law, holds a PhD and APRN, which is Advanced Practice Registered Nurse degree. She's also is an Advanced Oncology Certified Nurse. She's Associate Vice President, Nurse Scientist on the Cancer Service Line at Baptist Health Systems, Kentucky and Indiana. She oversees 9 hospitals. Her PhD came from the University of Kentucky in 2017. Her Master's of Science in Nursing research option was from St. Louis University in '91, and a Bachelor of Science in Nursing from Vanderbilt University in 1986. She's a healthcare executive in oncology and has worked in advanced practice oncology roles as an oncology clinical nurse specialist at Baptist Health Lexington in adult oncology, and at St. Louis University in adult oncology and stem cell transplant. And her experience as a staff nurse in adult oncology, bone marrow transplant, and critical care. includes St. Thomas Hospital in Nashville, Tennessee, St. Louis University in St. Louis, Missouri, University of Kentucky, Markey Center, and Baptist Health Lexington. She edits science nursing magazines. She's been on several boards. Her bio is just incredible, and I just want to mention 2 awards she received before we bring her in. And one was she was selected as the 2008 Advanced Oncology Certified Nurse of the Year, awarded by the Oncology National Certification Corporation. And in 2021, she was awarded the Vanderbilt School of Nursing alumni, an award for distinguished career in nursing. Dr. Yackzan is very knowledgeable. Susan, thank you so much for being here tonight.
Thank you, Mahia.
And
I'm feeling very mature right now. That's what I'm going to call it.
But hearing all the information you've gathered over the years.
Yeah, all the years, yes.
Well, and I know you pay so much attention to inclusion and diversity, and I know that's why you wanted to make sure we talk about the health inequities, as well as let people know about treatments and detection and the inequities, stemming from there. I also know we want to dedicate this show. Tomorrow's would have been my mother's birthday. We lost her to cancer. And Susan was an incredible advocate and is, for so many people, an incredible patient advocate. She's just passionate about giving people information they need to make the best decisions for their lives. And Susan, sadly, you also lost a parent to cancer.
Yeah, my dad. So in 1992, 3 days after my firstborn was born. So very difficult time, but we're not unusual. Probably statistic is about 4 out of 5 families are touched by cancer personally, in their lifetime. So it's unfortunate. And we're going to talk a little bit about prevention and early detection. And I'm glad that we're dedicating this to Morwenna. Wish she could still be here with us.
Oh, thank you. And your father too.
Yeah, thanks.
So where do you want to begin? You have so much information that you want to share.
Yeah, so let's start just by a general overview. So we'll talk a little bit about cancer treatments. So there was a lot of stuff in my bio that sort of touched on different ways that we treat cancer. So I think that's a good place to start. So surgery is the thing that most people are familiar with. Well, let me even start more basic. So oncology and cancer are words that are used interchangeably. Oncology is what we call the science of cancer, and it's a Latin root word. So onc really means tumors. So it's the study of tumors, and that's what oncology means as a specialty. And as you said, I'm an oncology nurse. So, I do want to do like a medical disclaimer. I told you I would, so whatever we say here tonight, there's a lot of personal risk factors and things that are very important for every person to discuss with their physician and their healthcare providers about their personal risk. So we'll speak very generally. I definitely want to say that. So oncology, the oldest treatment for cancer is surgery, and it's still one of the best treatments that we have. So more cancers are cured with surgery than any other treatment. And surgery is a very good treatment, most especially for what we call solid tumors. So those are tumors that are in many organs in the body. And surgery is a curative treatment when you can take it out. And so that really means that it needs to be contained and you need to be able to remove that tumor without doing any significant damage, right, to the body that's left behind. So it's a challenge, for example, in brain tumors, for example. So you can't, just take a lot of tissue out in a brain tumor. So early detection is incredibly important for that. most of my career has been spent working with chemotherapy. And so that's the use of very special drugs that basically kill cells in many different ways. And what cancer is a disease of loss of control. And so cells really should pay attention to rules, and cancer breaks those rules for many reasons. And so we use chemotherapy really when tumors are liquid. So that would be like a bone marrow tumor or something in the immune system, or when it's spread and can't be taken out with surgery. Radiation is the use of radioactive waves of different types, and it's really very specific, so very targeted. So kind of like surgery, you have to have something that's small in an area that's sensitive to radiation, and you can spare the normal tissue around it. And then there's been this revolution recently with some drugs that we call immunotherapy, and they're really very fascinating. So in the last probably 20 years, it's been a significant growth in our therapies, and we are having great success actually. And it's really using the immune system that you have and capitalizing on it. And so we've known for a long time that people who have challenge in their immune system, so they're immunosuppressed, are more at risk of cancer. And so, for hundreds of years, we've known that the immune system is important, but haven't been able to figure out how to use it to the advantage that we have now. And so these drugs you hear advertised on TV all the time now, and it's really revolutionizing things. And they're given by injection or infusion. But I do a lot of that kind of therapy too. So that's like the most basic overview of cancer treatment that we can do in like 5 minutes.
And that's accessible now for people who have access.
So lots of different tumor types. Yeah, it's pretty exciting. So really, lung cancer has been a difficult cancer to treat for a long time, and there are different types of lung cancer, but non-small cell lung cancer, for example, some of these drugs have just revolutionized that. Melanoma is another example. So many of you may know Jimmy Carter had metastatic melanoma, and he got 2 of these new drugs and had just an amazing response, and is still doing well as of today. So so fascinating stuff.
Yeah, that it's amazing to hear of another scientific revolution. Very encouraging.
It's good. It's good. Now, I think about the intro, and I made a joke about being mature, but when I started in oncology in 1986, we didn't have a lot of successes, so there were no mammograms. So early detection of breast cancer didn't exist. So patients came in with breast cancer because they felt a tumor or they saw a tumor. So in my career, I've seen phenomenal scientific developments in screening and early detection. So if you want, that's like a perfect segue to talk about screening and early detection.
Yes.
Okay. So I think we'll have a site that we'll put up that's really just an American Cancer Society good general overview of screening. And again, this is a good place for a disclaimer, so this is something that everybody should talk about with their healthcare provider. Some people have increased risks of some cancers, and so the general screening recommendations would not apply to them. So they may need to start screening earlier. So if you're in a family where there's been a lot of colorectal cancer, for example, and there might be an inherited genetic mutation, the general recommendation is that you begin screening with colonoscopies or sigmoidoscopies. So some screening for colon cancer at the age of 45, it used to be 50, but the American Cancer Society has lowered that now, and the U.S. Preventative Task Force to 45. If you have an inherited mutation in your family, you may start screening at 20 or 25. It depends on the specific family. So that's why it's important to talk to healthcare providers. Colon screening beginning at 45 for the general population. breast cancer screening. So women, should start screening. And again, based on personal risk and family history, maybe earlier, but at least at age 45 and annually. Cervical cancer screening, I believe the current recommendation is 25. Lung cancer screening is kind of interesting, and it might get us into a nice segue for talking about disparities, because something really exciting happened this year with lung cancer screening. So the current recommendation is that if you are between the ages of 50 and 80, and it used to be 55 and 78, and you had a smoking history, so you smoked at least, this is complicated, used to be 30 packs per year, and that's like a multiplier. So if you smoke 15 years, 2 packs a day, that equals 30, right? If you smoke 10 packs a year for, 3 packs a day for 10 years, that's 30. I didn't know I was going to have to do math. I should have thought about that.
I'm not even trying to do it.
Yeah. Anyway, smoking history, certain age range, and you quit smoking, either you're a current smoker or you quit smoking within the last 15 years. There is a CT scan that we recommend, and it's a low-dose CT scan of the chest, and it's a lung screening test. So we've been going with that basic guideline for quite some time, and just this year in March, the U.S. Preventative Task Force, after a significant amount of research, realized that women, African Americans, and Hispanics smoke differently than Caucasian men. And so those screening guidelines were established for Caucasian men. And what the realization was is that, African Americans and women smoke earlier, perhaps, or smoke longer on the same cigarette. And so the U.S. Preventative Task Force actually changed the recommendations in March, and they dropped the age. And so now it's 50 to 80, used to be 55 to 78, and they lowered the pack year. And so it's a recognition that different people smoke differently. And it's really the first time that I've seen a recognition of that, widespread in a recommendation. Now, the bad news is that insurance companies don't necessarily cover those new screening guidelines yet, and they probably won't until the Center for Medicare and Medicaid Services takes it up and decides to do it, and they're meeting in February. And we've all written letters that we're in favor of it. It's the right thing to do, but it gets us into a mindset where we're not just making a blanket statement about everybody behaving in this way, and we start looking a little differently at behaviors and risk, and it's so important. So, yeah, it's good news.
And that was just this year, this March, you said?
It was, yeah. So CMS, the Center for Medicare and Medicaid Services, like I said, they have to agree to pay for the new screening guidelines. So expanded age and lower pack year history. And they will be considering that. We just finished a period of public comment, so in the national healthcare coverage, before they agree to cover something, they'll send out announcements and they'll have a period of public comment, so that just closed on December 17th. But I know I wrote a lot of letters. And so all 9 hospitals in our healthcare system, produce letters, and we're very much in favor of that. I don't know how you would say no to that. And as soon as CMS covers it, then other private insurers will cover that. Medicaid would cover it. So it's really important, but it's really our first step in looking at different populations, disparate, a cancer occurrence, and thinking about the way we need to cover things differently. It's really important.
And that leads me to ask you about social determinants. Great.
Okay. Nice. We've segued very nicely into this. So I was thinking about this today, as I was kind of reading some things and trying to prepare for tonight. So if we think back, just like I told you about when I started in oncology, and, we didn't have a lot of screening, and I lost, the bulk of my patients. And it's just, totally changed, so now we do more prevention and early detection. Cancer incident rates are dropping for overall statistics, but they're not dropping for everybody. Cancer mortality rates are dropping overall, but they're not dropping for everybody. And so we've spent all this time trying to do something important about cancer because we were just kind of helpless in the beginning. And we made all this progress in what we would call the biologic aspects of cancer. So the biologic determinants, we know more about the cancer. We know more about specific mutations that happen inside cells. So we know more about the biology. And now it's like the funnel is getting bigger, and we're starting to look at what's upstream from that. And that gets us to a conversation about social determinants of health. So I mentioned that mortality was decreasing from cancer because treatments are better and because early detection is better, but that's not the case for everybody. So there are drastic differences in the mortality gains in Caucasian population versus the African American population, or the Native American population, or the Alaska Native population. And we've got to do something about that. And that means we need to go upstream from the biology, and we need to look at social determinants of health. We can have the best treatment in the world, and if somebody doesn't have transportation to come to our center and get it, or they can't afford it, or we send them home with a oral chemotherapy medicine in a bottle, and they don't have the money to afford that prescription or the health literacy to understand how to take it, then we're going to fail. And so social determinants of health is a broad concept. It's actually not new. So the World Health Organization had a definition in 2008. I actually pulled it so I wouldn't mess it up. And it's the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. So that's what social determinants of health is. And again, it's the upstream things that we need to think about.
Wow, that's so sad. And who has access to healthcare and who doesn't? And did you have some statistics to share?
Yeah, I looked some stuff up today. So I've tried to have some current things. So I mentioned like overall 5-year survival. So overall, all cancer types, if you take all cancer types together, overall 5-year survival is 67% in whites and 63% in blacks. So there's a difference. Overall, if you looked at specific cancer types, there are many that you would see that same thing and even greater differences. And so it's just incredibly important that we start talking about this. American Indians and Alaska Natives have mortality rates that are 51% higher than whites. Lung cancer incidence and mortality are 3 to 5 times higher in some rural areas, like in the state that I'm in Kentucky, than in a state like Utah or California. So another social determinant of health is rurality. So what your zip code is, and where you live, and do you have healthy food available? Not only transportation, but can you go outside and exercise?
And what's the air quality and what's the water quality?
Absolutely.
Which my very first guest talked about environmental racism. It's just definitely a social determinant.
It is, absolutely. So all of it. And, healthcare, we've been very busy trying to treat the biology and make some gains, but I don't know. I would say that the social conscience in cancer care, has been changing just like in most of society, thankfully. And we're looking a little differently at things. And as a healthcare provider, one of the things that I do now in my executive role is think about cancer care delivery. So I'm not at the bedside anymore giving chemotherapy or, talking specifically to patients. And so now I'm trying to design the systems. So, for example, when we do intake, so when a patient starts with us, are we asking about social determinants of health? And the answer has been no, we're not. So we'll get specific things like a family history. There might be a social history, a personal medical history in the intake document. But in our cancer centers now, we automatically have a visit with a social worker. In our cancer centers, we're doing a special screening for distress. And in distress screening, there are specific things that are asked about practical problems. So do you have transportation problems? We look at barriers to care, so in one of our centers, we actually have a survey that we ask, and we say, we actually ask about mistrust of the healthcare system. We ask about, ability to read and write, in addition to some of those other things. And we're starting to hardwire that into our medical records now, actually, so that everybody can see that. But I can't tell you that it's commonplace. It hasn't been. So it's just now developing. But it's incredibly important that we include that.
Thank you for including it. And I'm glad you're in a systems position to help make this happen more and more and more. And so then there's great concern about access to early detection.
Yeah.
Right? Who gets early detection, which certainly increases chances for survival, is likewise limited.
Absolutely. So everybody knows about the Affordable Care Act. So there is very good research to show us that the states that expanded coverage after the Affordable Care Act increased early detection and screening. So people did come to have mammograms because they had coverage to afford it. They came and had colonoscopies because they had coverage to afford it. So it made a huge difference. Now, that doesn't mean that everything got taken care of. We still have people that have no transportation, to come for their mammogram or whatever. And that's, again, why it's so important for us to be asking about that. And it's important, and you could teach me on this. So I'm going to take your advice, but how we have that conversation becomes important. And I would say that we're not very well set up for that in most healthcare settings. So just even the conversation about financial difficulties is very difficult to have with people. People are proud. They don't want to we make them bring tax returns in and utility bills and, apply for charity care. And it's a very difficult thing to do for people to ask for help.
It is. It is very draining. And I think one huge aspect that can help that ease the tension of that is when they see that you are advocating for them, that you want to get the best possible care. And when they feel that in your attitude, when they know, I'm sure how people felt when you were by their bedsides, that your passion for their survival, I think that's a key piece of it, is knowing you would like to not have to put them through systemic questions, but we're trying to make the system work better. I mean, I did work with doctors before, training in intimate partner violence prevention, and when we had to ask, and it's true, we do need training in difficult conversations, and how do we apply it into different areas. But I was based in a medical center years ago to help providers open the questions so that patients could reveal they needed help. They were being intimidated or threatened or hurt at home. So good for you for asking for support, because we can make it happen.
Yeah.
Really. And providers are just a really good avenue for
Well,
opening.
I mean, oncology, we generally have a great team, so, I mean, in the outpatient world, most cancer care is given in an ambulatory setting now. You really don't, get admitted to the hospital for most cancer treatments anymore. So you come and go, which, of course, if you have transportation issues, has its own problems. But I would say in the last 15 years or so, most cancer programs have a social worker involved, have a dietitian involved. And so many have, I'm losing the word, complementary medicine or integrative medicine programs, so we're becoming more inclusive. I think if you have those services and you're all at the ready, as you enter the system, it makes it more commonplace and acceptable, but the team is incredibly important. And navigation is something, so in the 1980s, actually late 80s, there was a little experiment in Harlem, actually in New York, and a physician who many people would recognize his name, Dr. Freeman, thought that if he brought somebody that was part of the community into the medical center to try to help with screening and early detection, so they offered free mammograms, but they also had someone from that community who was the connection, and showed, without a doubt, that having somebody that understood the clients who needed the services and how to help them navigate, which is how the term navigator was born, it worked wonders. So many cancer programs now have navigators, and we do it a little differently, but the Indian Health Services uses navigators, so if you have a Hispanic community, you really need somebody who speaks Spanish, so we're getting better. I'm not going to tell you that we're there, but this upstream conversation is happening, and it absolutely needs to be.
Great. Gosh, thanks for giving us a picture of the stage it's in right now. And thanks for helping it happen and grow.
Well, like I said, it takes a team, and we have great teams of people who really care. The goal really is health equity. And, there is a lot of conversation about it, so integration into research is incredibly important now. Advocacy and health policy is another aspect of it, so if we don't have laws that will support what needs to happen, we need to get those changed, so I talked about the public comment period for CMS. We need that to happen, so the public comment and the public policy is incredibly important as well. So it's a lot of different aspects of people working together to make change.
I wanted to ask you, because I'm a layperson, and I believe in science, but there's so many things I just didn't know, just ignorant because I'm not in the medical world, that extra struggle related during COVID, like during a pandemic, I think a lot of us were worried about, in general, elective surgeries not being possible because of the onslaught in hospitals and of COVID patients and that continuous emergency. But I think of like cancer patients like that doesn't feel like elective surgery. That's not elective, so I don't know if you can share like the extra challenge if you have cancer and there's this rapidly spreading virus and how your system can cope. Can you share a little bit about that?
Yeah, so that was a real struggle. We're still seeing the effects of that, for sure. So when we shut down elective procedures, it did not include cancer surgeries. But I will tell you, there were other things that are sort of ancillary surgeries or extra surgeries that help cancer patients. So for example, some of our patients need devices that access their central circulation, so instead of putting a little IV in your hand, like, if you go to have a colonoscopy or something, we need something that's bigger. And so because of the drugs that we give. And so we were advocating that those were not elective surgeries. But that was hard because there wasn't any PPE, right? And so there weren't gowns and gloves to go around. And we did a lot of that, advocating for the cancer patient who needs the surgery. And it's important because, it'll affect their treatment. So in general, elective surgeries did not include cancer surgeries. But there were some other things that we were having discussions about, I guess, and advocating for. The big effect that we're actually seeing, and it is very true, is that screenings halted during COVID. So we didn't do lung screening like I was talking about, low-dose CT screening. So that was shut down. Mammograms stopped for a while. And, many people, you get involved in life and you might be late for your annual mammogram. Well, if you're already late for your annual mammogram and it was March 2020, then you were a year and a half late, and then we had a backlog, so it might have been 2 years in between your mammograms. So unfortunately, we are seeing a higher rate of more advanced stage cancers being diagnosed because screenings were halted during COVID. And this is an effect we're going to see actually for quite some time. And it goes to everything, right? So people weren't going to their primary care physician. So they weren't getting their regular annual checkups, or anything like that. So symptoms they just were handled and managed. And, so we are seeing late diagnosis. So, if there's anything that people take away from this is that, it's time. If you're due for your screening, please go get it. Please talk to your healthcare provider. Early detection is incredibly important. If you need help getting screening, I would encourage you to, call social workers, call your health departments. There's a lot of resources in many communities that can help you with screening. Call the American Cancer Society, but that certainly it's definitely an effect that we're seeing. And it almost, it takes me back, unfortunately, because we just kind of went backwards with screening. And then it was difficult for patients to come in because their cancer patients undergoing many treatments were at increased risk. And they were actually in the high risk category, and, with higher rates of hospitalizations, higher rate of ICU stays, and higher mortality when they got COVID. And again, I'm making a blanket statement, but primarily the immunosuppressed patient, so patients whose immune systems were tamped down by their therapy, or they're that way because that's their cancer. So their cancer is affecting their immune system. So either one made them more at risk for COVID and more at higher risk for more serious cases of COVID. So yeah, I mean, we didn't do a lot of in-person visits. We switched to telehealth, and that created challenges of its own, although I would say in the long run, it's probably a fantastic thing that's going to come of it. It's probably the silver lining of COVID. However, back to our social determinant conversation, not everybody has a computer or, an internet connection that can do telehealth. So we're still trying to deal with that as well. And then, I know vaccines, can be a political topic, but I'm going to tell you as a cancer nurse that I take care of the patients who don't have immune systems. And again, that's either because of their cancer. So if people have a cancer of their B cells, like certain types of lymphoma, they really cannot make adequate amounts of antibodies. So even if they get a vaccine, they're not what we call immunocompetent, which means they cannot produce the antibodies from the vaccine. And so they are at increased risk for getting COVID, and there's nothing they can do about it. It's, because of the cancer. Many of the therapies that we give cause immunosuppression. And that can be chemotherapy. It can be some of those immunotherapies that I mentioned, and it could just be high doses of steroids, which we use frequently. And they may not be able to mount an immune response after getting a vaccine, and they're at increased risk of COVID. So those of us who work in the field of cancer with people who are immunosuppressed, I mean, I feel incredibly obligated toward public health. The last thing in the world that I want to do is bring something that serious to my patients or into a cancer center, and so me getting a vaccine and taking care of containment and mitigation efforts, so following the recommendations of public health is important because my patients don't have an immune system and cannot really be vaccinated like I can, and be protected. And so it's my obligation to try to help keep them healthy.
Well, I really appreciate the public health service message. That's what I'm hearing. A public health service message that if we have immunosystems that can respond to vaccines, if our health will allow us and we have access, it's for the sake of public health for all of us, not just ourselves and our family, and to think of people who just cannot
I mean,
get
that's
the
what
vaccine or take it or
follow the recommendations. Yeah, absolutely.
Thank you so much for
Mhm.
that.
Sure. On the social determinants kind of conversation, during COVID, a colleague of mine in St. Louis, we actually published an article in one of the journals of the Oncology Nursing Society, and it was really a public health primer for oncology nurses. So oncology nurses, we have our own specialty. We're not really public health nurses, so it was a way for us to get public health information into the oncology nursing world. But one of the things that we looked at, and the colleague that I co-authored this article with is from St. Louis, but we looked at the health department in St. Louis and the zip codes, and it was kind of very dismally interesting. So 3 of the 4 zip codes in the city of St. Louis that had the highest poverty rates also had the highest incidence of COVID. So again, those are the people who are riding public transportation. Perhaps there are essential workers. So they're the people working at the grocery store and maybe riding a bus to get there. There are large groups of family members, perhaps in housing. They may have a food desert in that area of poverty where they have to go a long way to go to a grocery store. So their risks of exposure were more. And again, it's because of the social determinants of health.
Yeah, that I really appreciate that definition of social determinant that you read earlier. Wow. I know we just have a couple minutes. I wonder if you wanted to share anything about the state of Kentucky specifically.
Yeah, so I grew up in Kentucky. I lived away for I don't know, about 15 years, and came back here. And we unfortunately have the honor of having the highest incidence and highest mortality rate from cancer. So sometimes we switch in some of those statistics with a couple other states. But the most recent stats, we were right up there at the top. A lot of it is lung cancer. So the smoking rate in the state of Kentucky is very high, but we're a very rural state. We have a lot of poverty in certain areas of Kentucky. So these social determinants of health are incredibly important with the patient populations that we take care of. And, in my system, we have 9 hospitals, and a couple of them are urban, but most of them are rural. So these issues they're everyday issues for us. And getting the word out about prevention and early detection is fine, but we have to do something about what people can do about it. We can't just tell them they need to do it. We need to be looking at what we can do to help them.
And is there like a website where people, if say they want to like add to public, when there's a public commentary period of time, would the American Cancer Society website have, how can people who want to advocate and pitch in their voice contact?
So CMS, they publicize it, but public comment periods open and close, so I'm not going to tell you that it's easy to navigate. It really isn't. The American Cancer Society does have a public policy arm, and they're very good about getting the word out. But yeah, maybe I'll look and see if I can find something to post. But it's not an easy conversation. ACS is probably the best. The American Cancer Society is the best avenue of approach, I would say.
Okay.
Yeah.
Wow. Susan, thank you so much. The time flew by. I'm so grateful to you, and I wanted to let listeners and viewers know that if they are interested in trainings such as the one you were talking about and having these conversations, because it does take building new vocabulary sometimes and how we ask questions. I can be contacted through my email, yackzan@gmail.com, whether it's DEI trainings for medical field or other fields to apply to different arenas. I am offering a class starting in January called Expanding Inclusive Consciousness. That's some are tailored to coaches and teachers, but I tailor it to the client body. So if you're interested, please contact me that way. And I just, again, want to thank Dr. Susan Yackzan for your knowledge and for your passion and for your patient advocacy and your systems change work to make it more inclusive. This cannot tell you how important that is to so many people. And I also want to thank my viewers again and listeners, remind you to go download some shows from 2021 and looking forward to 2022. I want to say Happy New Year to everyone, and be sure to tune in next week to W4CY Radio or Talk 4 TV at 8 p.m. on Wednesday. And may we all have enriching conversations in diversity.
Inarticulate speech, inarticulate speech of the heart. Inarticulate